Okay, good morning, everybody. My name is Yazeed Almalki. I'm an echocardiographer at St. Mike's, currently in structural fellowship. So it is a last moment preparation for this talk. So both of us will be surprised with the slides. So if there is anything, just we will figure it out together. Good. So Dr. Chow always asks about the objectives. I have none, only to have fun together. So we want to talk, to discuss. I'm not teaching anyone. We are learning together. So M-mode is one of the first important modality in echo that helped in diagnosing a lot of diseases. And it was the first thing to use in LV Inflow. So I will not, the LV Inflow per se, it's like a long, huge topic to cover it with the disease, with everything. So I will just talk briefly about the M-mode of the inflow and also about the pulse Doppler of the inflow. And the majority of the talk will be like, it will be cases, and we will learn together in the cases. So what do we have in the M-mode here? Anyone knows the names of the signals here? So I'm used to this silent response, so I will take it from here. So this is diastole. Let me try to show the pen. Okay, so from here, it's the beginning of diastole, where the mitral valve open. So what we'll call this one? D, diastole. So, and then we will have our early filling, or passive filling, they will call it. So what we will call this one? E. Then we have this slope. I don't know why, but they call it the F slope. And then we have our active filling, or atrial contraction. So we'll name it A. And then we have the closure of the valve, or the beginning of contraction. So we'll call it C. So currently, we don't care about these names, most of us, but for me, it's still important. I consider myself from the old, like, dinosaurs and old generations. If you see the M-mode has high temporal resolution, you see some cases that you will see things with M-mode, you cannot see it with 2D, with your eyes. Your eyes will miss it. The frame rate and eye cannot pick it up. The M-mode will show it for you clearly. Any abnormality in the inflow, it can be first shown here. When they started echo, they used to have only M-mode. So they used to diagnose everything from M-mode. Ejection fraction from M-mode, LV volume from M-mode, mitral stenosis, mitral valve prolapse, tumors, you name it. All from, even like, oh, this patient has low cardiac output, just how the aortic valve open, like it's tapering, not tapering. It's a whole science. So this is the waves. And I want to refer you to this lecture. It was very nice. It was one of the most detailed things I have ever seen in M-mode, just for the mitral and the aortic, which is good. So we will have a period of diastole, and there is a diastasis in the middle. This is why the valve will almost come back to baseline, because there is low flow or none sometimes if the patient is a little bit in the lower rate. And then you will have the atrial contraction, and the two lines, which is the anterior mitral valve leaflet and the posterior, will come together and join, and the cycle continue and continue. For example, if the patient develop atrial fibrillation, there will not be a contraction. If the patient develop atrial flutter, you will have multiple A's. If the patient develop, if there is thickening, you will not see this thin, nice, crisp line. Every disease, it has its own finding. If something happened during systole, if something happened during diastole, what will be if there is masses, like vegetation or whatever? So this is the most common thing that we see all the time. Any idea? So stenosis, mitral stenosis. Why it's mitral stenosis?
Decrease in EF slope.
Yeah, we have the loss of the F slope. Huh? We have the loss of the F slope where the valve will open and it's restricted and continue. However, if you notice also, even the posterior will be pulled by the anterior and continue like that. So what if we have mitral stenosis? But what's the difference in this one? This one still have the atrial kick, still in sinus. However, this one, atrial fibrillation. We don't need ECG anymore, isn't it?
Yes.
Yes. So how about this one? What do we find? Flutter.
Flutter.
Patient can alternate between atrial fibrillation and atrial flutter. And if you see by the 2D, you cannot notice that this is the same patient. You can see the flutter very nicely in the M mode. However, here it's just something moving around. And if you are, oh, I thought I put another image. It's okay. How about this one? SAM. Yes. Why we say SAM? Because during systole, this is supposed to be in the midline. However, it's going there. Okay. What else other than SAM? Something we'll come to it later. So we have E, then we have A, which is here. Then we have this. What do we call it? Yeah, it could be. With the diastolic dysfunction, this patient could have P bump or P hump. Any idea why we have SAM? What's the idea of SAM? So we can see now, you can see the LVH here, and you know that during systole, he will have SAM. So what will happen? It's like what they call Venturi effect with the high velocity going through the LVOT. It will pull the anterior mitral valve leaflets, and there are degrees, like how much do you, like how the length of the SAM during the cycle. Is there a contact with the septum or not? Like this is how you diagnose your patient, how severe it is. And this is all used to be diagnosed just by M-mode. Like they will see, is it more than 10 millimeter or less than 10 millimeter to see the risk? And they will check how much of the cycle, this is systole from here to here, how much of the cycle. For example, this patient took almost all of this, like more than 50% of the cycle. So this is a higher risk patient. So what is this one? AI. Mild, moderate, severe. AI. What do you think?
Moderate.
Moderate. Any idea? At least moderate. Yeah, you know, in the interventional side, they hate this word, at least moderate. They say, if you want to say severe, say severe. Just say it. We will clip the patient. We will put a valve. Anyway, just say severe for us. So for this one, you cannot tell the degree of severity. It is just the jet. The jet is hitting like eccentric and going. And if you can see the leaflet here, it's a bit bowing like that. You see it, I don't know if it's clear or not. It's a bit bowing because of the jet. It does not indicate the severity. Always people will fall for this one and say severe AI. How about this one?
Although I guess
Dilated LV.
yeah, there's the dilated LV, but the other sign of severity would be premature closure. Oh, okay, so
I'm happy that I closed the video. Otherwise, you will see me doing like. So this is the premature closure of the. So what will happen? There will be high LVETP. So the LA is filling and the aorta is filling, and the aorta pressure is higher than that. So if you see here, the valve will close very early. This is a premature closure. This is one of the signs that people I remember some of the old folks, they will say, is there a premature closure? If they see this sign, this patient should go for surgery like immediately. This patient will not survive. How about this one? MVP, most valuable player. Yes, it's mitral valve prolapse. So which leaflet? Anterior, posterior, both? It is by. So if you see here, it's depend how you put your M-mode, and then you can catch it. So they used to diagnose, is it a Barlow or not, by the thickening of the leaflets, by the prolapse, and how much it's prolapsing. All used to be done just by M-mode. And I have seen some of you will do it also from the short axis. I don't know who did it, but it was like one of the nicest. Because of the short of time, I did not have time to prepare it. So this is, again, anyone? I should bring presents next time. Mom, I don't have cash
Septal
on me.
separation, decreasing
So this is,
contraction, dilated ventricle.
yeah. So first of all, as Dr. Chow was saying, there is dilated ventricle. We call this E-point septal separation, and which we don't use anymore. And the most important thing is the hemodynamic part of it is the B bump or B hump, which indicate high pressures, like LA pressure is really high. So still pumping blood even during or after the atrial contraction. It's supposed to be like emptying now. How about this one? Prominent B bump or what? So what is this one? Any idea? So what do we have? We are supposed to have E and A. So if there is something extra, yeah, it could be an extra A. This patient has 2-to-1 AV block. Okay, and I have seen a couple of patients, they will have like that. And you will see like this. You can be the first to diagnose those patients. And I have seen a couple like they will be seen and do the echo, go home, and then we will discover by echo that they have atrial fibrillation, atrial flutter, 2-to-1 AV block, that it is not diagnosed. So we are one step ahead of EP in this matter. So you can diagnose it, and to clarify that, you can do what? Either to pulse the M-flow, which we do routinely, or look carefully at the tissue Doppler. You will have multiple A's. Okay. So what is this one? Whoever bring it is the.
It's on Dr. Wayman's book and Dr. Feigenbaum's book cover.
Oh, Grace is killing it here, Dr. Chow. Yeah, as usual, as usual. So this is a mass.
A mass prolapsing in diastole.
Oh, thank you. Huh? I mean,
into the left ventricle.
So why I brought
like
this?
A left atrial myxoma.
It's the left atrial myxoma. You can see the mass here, isn't it? It is as this big. This was here in St. Mark's, by the way. And this patient came for another reason. He has a mass in the tricuspid valve and like PE something, and then found this one. And why I brought this one? What's the diagnosis between those two books? So this is the same thing. It's the if you remember the M-mode, it's supposed to be empty from inside, isn't it? How about this one? It is filled. There is something inside it. So Dr. Robert Howard told me that diagnosing left atrial myxoma was the biggest victory in echo when it started as M-mode. And he told me this is why the books put this one. Feigenbaum is this book is the first book published in echo, 1972, I think. Dr. Shao can correct me. He is always remembering things. And he said because usually patient will die suddenly, and then in autopsy they will find that he has myxoma. Always it's a retrospective like diagnosis. After he died, they will know that. When they start to diagnose it by M-mode and later by 2D, they consider it one of the biggest victories. Mitral stenosis, mitral regurg, aortic stenosis still can have some clinical hint, but for this one, it was the best. Dr. Kim, any comments, or I saw you?
No, I mean, fortunately, I was too young to hear about.
Okay.
We had 2D, but
So he's our chairman, and I'm forced to believe him. But so how about the mitral inflow, the Doppler? So the Doppler, all of you are doing a great job, and it's just to note like a few things. Where should we pulse? Always at the tip of the mitral valve leaflet, and they say usually the flow go more toward the lateral, not central or not toward the aorta. This is the normal flow. They say if the heart is like that, I'm bad at drawing like this. So, and this is the heart. The flow is normally going like that in the heart and going out. This is the normal flow of the heart. Where do we pulse? At the tips. Do we pulse at the annulus of the aorta, of the mitral? Kathy? Do we pulse? Yeah? When do we pulse? When do we pulse at the annulus?
Oh, if you want to calculate for
Yes, for the stroke volume of the mitral. We use it sometimes to calculate. We use it for two reasons. One is from time to time, if we want to calculate the stroke volume through the mitral valve, we can use it just to see how much is the regurg and these things. And the other one, which is really uncommon, for atrial wave duration and diastolic dysfunction. However, I don't advise that, especially in the presence of Dr. Kim. Okay, he doesn't believe in it. Yeah. So you saw his hand, like, never do it. So what is this? What do they call this signal? Modal velocity. What do they mean by modal velocity? It's to be crisp in the outline. This is, you know, that you are exactly measuring the velocity at that point. Whenever you have thickening or broadening of this wall, it's mean that either it's contaminated, there is high velocity, there is turbulence, or the pulse volume is too large. So the better the crisp, that you know that you are sure about your calculation, your signals, and your velocities. What do we get? We get the E velocity, the A velocity, we get the deceleration time. We can get also sometimes the acceleration time. We can get E over A, E over E prime, many things we can get. This is tell you about the importance of this image. And if you look carefully, it's really compatible with the M mode. So you'll have E, which is prominent, and then A, which is less in the majority of patients. And whatever you see here, you will expect to see it in your inflow. Both of them together, they should make sense. You cannot have atrial flutter, for example, here, like that, and then you will come here and say, okay, this is E over A, and this is A, like that. And we will see examples of that. We talked about this one already. So what do you think about this one? This is cases now. Done with the talking. There is no talk. Any idea? No, they wrote this one E, and this is A.
Yeah.
Do you think it's correct or not? And why? Yeah, there is no A. Even this one, it's like that. So what do you think this one? Is it A or not? So what is it? It's an L wave. It's a sign of high LA pressure. Okay, and when to diagnose it, whenever they say that whenever the velocity exceed 20, whenever the peak velocity exceed 20, this is an L wave. And if you didn't recognize it at this moment, you still have a chance. Echo give you a second chance, a second reminder that you still have the tissue Doppler. This is the same reflection, by the way. This is the same reflection in the middle, that the LV is still expanding, still receiving blood. This area, this time, is time of diastasis, supposed to be empty or no significant flow. Whenever it's exceed, you can see it sometimes if the patient is very brady. However, we always never diagnose a patient condition from one image or two images. We put everything together. So what does Dr. Chow call this sign? Batman. He already said it. He killed the fun of this.
I'm sorry, that's my favorite sign.
He called it the Batman. It took me time to find this logo.
Oh, you need the Batman hat only.
Yeah, so he called it the Batman, but in the real world they call it the triphasic flow. Okay, they will call it like ELA. So triphasic. It's really look like a Batman. First time to hear it as a Batman it was from Dr. Chow. He said, "Do you know the Batman?" I said, "I don't know the Batman." So what do you think of this Batman? What's wrong here? It's a nice E. It's a nice A. What do you think of the deceleration time? This patient was diagnosed as grade 3 diastolic dysfunction, high LA pressure. You can see the flow here, isn't it? And you can see it's reaching like 50. But what do you think about the deceleration? So he or she or whatever, but I always say she because the majority are ladies, even back in Saudi. So they get the deceleration time of 260. If we correct it and take the same point that she took it, but we follow the crisp line, we will get around 160, which is compatible with the diastolic dysfunction of this patient. These, maybe it's like, whatever they say, like a moo point or whatever, but remember that these things are in the chart. When someone wants to do a research and these things should be like in the right way. And sometimes people will just follow the numbers. For us, like in the structure, most of our patients come from other clinics, from other hospitals. We don't have the images. We just depend on whatever in the chart. If they say the aortic stenosis mean gradient is 40, we will consider it 40. We don't know how did they measure it, but we trust them, and we should have trust in our measurement. How about this one? Everything is correct, isn't it? However, when we have EA fusion, for whatever reason, we cannot really use this deceleration time. I don't know, do we still put it? I think we should keep it. I don't know, but it is inaccurate. It is totally inaccurate, this one. Because when do we say fusion? Whenever the E catch the A, like or what they say, the A wave uptake is higher than 20. Which happen in tachycardia, which happen with AV block, happen in left bundle. Many diseases will cause this one. And funny thing that this is here, this is back in Saudi. It's like the same things happening. And you,
in this case, can at least measure the E?
you can measure the E, but you know that your A is overestimated. Your A is overestimated. And if you go by diastolic dysfunction guidelines, they say you cannot use them. Yeah, you cannot, because anything, see, to diagnose diastolic dysfunction, it's really tricky business. And if you see the list that things that prohibit diagnosing, it's so many. However, they will give you hints that the LA pressure is elevated. This is maximum you can say sometimes. The LA pressure, there is, I would write sometimes, Doppler signs are suggestive of elevated LA pressure. This patient can go for further evaluation. I cannot tell from just few signals.
But it's part of the reason why I think they moved away from the old nomenclature with the pulmonary veins, you know, SD, decel time, and that into this sort of multi-parametric where it's the LA size and the E over E prime, because the E over E prime will still hold up here. To give you guidance and the RVSP, and then looking at the ratio then to determine, you know, if you're grade 1 or 2. So that was sort of why it moved away from putting sync. Because remember, it used to be a lot more emphasis on the decel time. But you know, remember an atrial reversal and stuff, which are not reproducible, is the problem with it. So that's why
I remember I used to hear that they used to have more than 14 items to check is the patient is grade 1 or grade 2 or grade 3. Then they summarize it to these tables just to make it user friendly, like for everyone. These are supportive measures rather than diagnostic things. And you should put all the patient together. Everything.
I think, you know, the key here when you get this sort of spectral profile is to really, you do need to really go back and look though, are you truly at the tips of the mitral valves, and have you gone off axis to then look at the flow, as Yazeed said, which tends to come out and go along the lateral wall. Although the spectral profile here is pretty clean, so you would say probably it is good. The second thing that comes out, though, is often what we notice when the tissue Doppler is done, that often it's rotated a little bit and it's a bit more of a 5, and so the medial velocity is lower, which then overestimates the E over E prime and sort of makes it a bit harder to assess. That would be the sort of often not an uncommon scenario we see there. So I think, yeah, I don't, you know, the decel time's longish, which again, this is not great, the old grade 3 diastolic dysfunction. It's probably between 1 and 2. It's elevated LA pressure, and that's about as good as we can say.
I'm sorry. So in this case, shall we still measure it at least E and A velocities, or should just leave it as is? Like, just take a picture, don't.
No. We still want you to measure it though. Yeah. Because you can still get an E over E prime, which is then what we would do with the LA pressure and the RVSP, then to go back and use the ACE algorithm to then grade the diastolic dysfunction. So definitely this is still valid.
It's a correct measurement.
Yes, so
but
this is technically correct. It's just with the decel.
You don't depend on it much.
Yeah. But it's longish. I think it looks longish, but we don't really know, is it 280, 350, 410, or so, which is part of the reason why decel time sort of has drifted.
So this patient per se, I think he has this grade 2 because his previous echo was, or the after echo was like that. So most likely pseudonormalization, maybe diuresis or whatever, and went back. Yeah. Also, for the fusion, when you have fusion, you can see it also in the pulse. Okay. So if you like miss it here, or you are not sure here, you can always go to the pulse and you can see the representation. I'm not telling you what is right, what's wrong, what's happening. And
so just go back to image. But again, if you look where the sample volume's placed in the medial annulus, it is tricky. You know when it rotates around a little bit and you're not certain exactly where you are, which generally then underestimates the E prime, which will overestimate the E over E prime ratio, and that's not an uncommon sort of technical finding we see. And if you guys probably can't see it yet, but it's a little bit in no man's land there. And again, it's not uncommon. And obviously, it is a Doppler velocity, so you do need to optimize it to be vertical, to be parallel as much as you can, because it is Doppler, which means angle correction will cause you to underestimate the true movement of the medial annulus. The septal annulus obviously is a bit harder just because by virtue of where it sits in the chest, there is translation as well. But that generally overestimates it, as you know, because the lateral is generally higher than the septal. But
Kim, do you mean it's 2 into the RV? Is that what you mean? Like
exactly.
Okay.
Yeah. Or it's either often it's placed a little too high, not truly at the annulus, or it's rotated in a 5-chamber, and we're actually measuring somewhere into this sort of LVOT, whatever it is. And of course, that will then underestimate the E prime, which then will push up your E over E prime. So it makes it. So that's sometimes where we see the discordance. You're looking at it saying, the LA size looks normal, the RVSP is okay, the E velocity looks funny, but the E over E prime is 17. Usually then I go back, look at the E prime and think, oh, it's a little over rotated there. So it's probably 7 instead of 5, and that's enough to then push you into that, from that gray zone, indeterminate, to actually this is abnormal.
Sometimes I will see the sample volume for TBIs that more towards the LA. So where should it be?
No, it really truly should be at the annulus. So optimally, it should be your absolutely perfect, apical 4-chamber. Ideally, the septum should be vertical as much as you can, so then you're getting just truly apical to base shortening, and it should be at that crux location there. So that is the annulus, which is easy for me to say.
Yeah.
When you've got a patient lying down, respiration. But I think the commonest thing I would see is that the rotation, and it's a bit more of a 5-chamber as opposed to a true. And so then it's a little bit harder to know. And the way you can tell, again, just like instead of getting a clean spectral profile, you see a bit of a fuzzier tissue Doppler profile. I mean, tissue Doppler is still Doppler. It's still the same principles of spectral broadening and so on, regardless of whether it's annular velocities or actually blood velocities, which is the difference between the EA and the tissue Doppler E prime there. So if you get that fuzzy one, you know, I know we asked for 110 images, so I get it. But it is a common source of when that, and this has been part of the problem with diastolic function, and it is technically quite demanding to get everything. It's easy if you've got a young, fit, healthy person. We usually don't care about it in those folks. It's in the other where we're trying to say, is there a structural abnormality which then might fit with the heart failure preserved ejection fraction syndrome, right?
True.
Yeah.
So, as from the previous things that the M-mode and the pulse wave both are connected. Like for example, in this patient, you can see it as one. I think you can see it as one because of, for example, tachycardia, prolonged PR, and here you will have the same issue. So whenever you have problem with one side, you should revert to the other one. You see how things are going. The same with this patient. What's happening here? It is sinus. You can see the B wave.
That could be the A wave.
Yes, this is the A wave. This is the A wave in this range. It's usually somewhere here. And I have looked for patient with prolonged QT. I want to see prolonged QT or prolonged QRS, which cause like fusion. I haven't seen much in the literature, so I'm suggesting this as a project for the next fellows. They can search for that and have something. You have the EP department, and you can join forces. So it is the same idea. So they are very fused in this patient, which make you like, in the first glance, you will think that this patient is like restrictive or advanced diastolic dysfunction, while it's just an A, rapid A. How about this one? Yeah, it's a random, just it's BVCs with the random beats everywhere, and this one from Saudi, this one from here. It's identical, huh? Yeah. We have the same patient. We have the same patient, by the way. Huh? So always look at the inflow. How does it look like when the mitral doesn't open very well, like that, this motion? You will know that you don't have the regular or the bass, the sinus rhythm or whatever abnormality. And then you can correlate here. This is a really just to show you how the M-mode can tell you about the inflow. The same idea. This is a beat, this is a different beat, and it was taken as EA. Okay, so the ECG, because this is BVC, some patients they have really like low voltage. I have now, since I'm doing the ECG myself, I can see it in the patient, and this is the same things. It's diffused, and why this patient has fused?
very long for 3 and 4.
Yeah, this patient has complete heart block. And when we go to his Doppler, you can see here there is an A, there is another A, and immediately, this is the medial. Immediately in the lateral, that A disappear and just you have one A. You see? So those patients sometimes can alternate between MOBS 2 and third degree AV block. How about this one? I think I have just 2 more cases and I'm done. No constriction, no tamponade. What do you think? No? No. This is common day-to-day patient.
Oh,
So I was told this like a long time ago, like as a hint. It's not in the books. I haven't seen it anywhere, but I was like taught by some of my teachers. Whenever you have variation like that, so the E here is a bit higher and here is more higher, and then it's come back. This is like what? Like pulse alpha. When you ask the patient, he is in transition. He is like almost grade 2, grade 1. There is some elevated LA pressure. It's the same mechanism when you ask the patient to do pulse alpha. This is exaggeration. So the patient will revert to grade 1, okay, with that inspiration. Just with the normal respiration, you may have this variation. This is one of the explanation why this variation. So my teacher at that time, he told me, like, I think 2018, he said, whenever you see this one, suspect grade 2 and like search it, why there is this difference. This is the last case. And this case, me and the fellows, we were like talking about it for a very long discussion. I came in the weekend to search something and I spent 1 hour searching for this case. Why this wave? Like seeing the echo. So this patient, when you do the pulse wave, you have your nice E. But when you do the CW, you have this flow. So it's coming from somewhere. When we did the echo, I noticed that the apex is relaxing in the isovolumetric relaxation time vigorously before the mitral valve open. So it is the flow at this region that it is detected. It is this flow. So this is why we have this like wave. This is the only explanation, unless Dr. Kim or Dr. Chow have another and debunk my theory.
Essentially, with that Doppler profile, you're seeing flow towards the apex
Yes.
before the mitral valve has opened.
Yes.
That's your point here, right?
Yeah.
So the explanation is that the ventricle relaxes, it kind of sucks blood towards the apex, which causes this profile before the mitral valve has been opened.
The sad thing, I took a picture by my phone and I don't remember the case. I'm not lying, but this is the truth. Any
That's a better explanation than that.
So with that, I conclude. I hope you had fun. Although no